Good afternoon and welcome to Manchester Breast Centre. We are an organisation committed to breast cancer research in Manchester. We were founded in 2005 and we're part of Manchester Cancer Research Centre. We comprise 21 principal investigators and 17 associate members. We have a large number of lab researchers. We also have clinicians involved in prevention, early detection, medical oncology clinical trials, surgery, imaging and pathology. We are very closely linked to the clinical units across the whole of Greater Manchester, although our research is mainly based here at the Christie, the University and at Manchester Foundation Trust South, Wythenshawe Hospital, where the Nightingale Centre does both prevention but also breast cancer diagnosis. Today we're here for our public engagement event, which is called How Can We Predict and Prevent Breast Cancer Now? We hope it's going to be very informative. We have 4 talks and we have a chance for some questions and answers, some discussion at the end. We're sponsored by Prevent Breast Cancer, which is the UK's only charity devoted to prediction and prevention of breast cancer, who do gene research, early detection and screening research, and also test prevention drugs and diet and lifestyle. We are also sponsored by Breast Cancer Now. Breast Cancer Now combine both research and care. They support research across the whole of the UK, including a lot of research in Manchester. They also support patients on the ground through their life-changing support. So this is the programme for today. We're going to have 4 talks from Professors Cleona Kerwin, Gareth Evans, Charles Strawley and Sasha Howell, and a discussion led by Dr. Ahmet Ukal. So without further ado, I'd like to introduce Professor Cleona Kerwin, who's going to ask the question, how do I examine my breasts, and tell you what happens at a breast clinic. Thank you for listening.
Hello, my name is Cleona Kerwin. I'm consultant breast surgeon at Manchester University Foundation Trust or Wythenshawe Hospital. I wanted to talk to you today about what to look for when you're examining yourself, when you're looking for changes that might occur in the breast that could suggest you need to see a doctor to rule out the possibility of breast cancer. So first thing you need to do is be breast aware and examine your breast at least once a month. Probably the best time is about a week after your period, or if you've been through the menopause or aren't having periods, then just select a day that you'll remember in the month, so maybe the first of the month, every month. Key thing is, first of all, to look at yourself in the mirror naked and have a look at your breast shape. And what you're looking for is that there is symmetry in the curves and no changes in the curves of the breast and no changes in the nipples. But there's no signs of any skin dimpling or any shape change you haven't seen before. Do it by just standing comfortably, looking in the mirror, then you lift your arms up above your head and have another look. That lifts the breast up so you get a better view of the bottom of the breast, and then put your hands on your hips and push down to contract your muscles, and any lumps or bumps that could be deep in the breast then may become more visible. Then the next thing you need to do is actually examine your breast. So 2 good places to do that are, one, in the shower when you've got running water and you've got some shower gel on your hand, because then your hand slides over the skin easily. Or the other time to do it is lying flat on your back and examining your breast through your t-shirt. What you want to do is use the flaps or pads of your fingers and examine the whole of the breast. What you're doing is pressing the breast tissue on the rib cage. So the rib cage acts as a hard surface which you rub the breast tissue over. So if there's a nodule or a lump in there, you're likely to feel it as you rub it over the rib cage. Now you want to examine the whole of the breast, remembering that the breast goes from about right up here all the way down to where your underwire sits and goes from almost the midline right the way to halfway down the middle of your armpit there. So making sure you examine the whole of the breast and just have a logical order to it. So either zigzag back and forth the whole way, or up and down the whole way, or just starting at the centre and going round in circles. And press lightly first of all, rubbing the tissue around, and then press more firmer to feel deep lumps, and just get used to the natural lumpy bumpy feel of your own breasts. And if you do see any changes, then go and see your GP. And if they've got any concerns at all, they'll refer you in to see us so that we can check you out. Because they've got a very low threshold for referring patients in. Because we always say that we err on the side of paranoia when it comes to breast cancer, because unfortunately breast cancer is common and affects 1 in 9 women. And in fact, of girls born today, it's likely that 1 in 8 will develop breast cancer. So it's an incredibly common disease, and the best tool you have is being breast aware, and when you hit the right age, going for breast screening from about the age of 50 until about the age of 70, and always reporting any changes to the doctor. So in a particularly current climate of COVID, many people are wondering, well, what happens? Should you go and see the doctor? Aren't hospitals scary, risky places to go to? But the whole system has been made incredibly safe. For example, lots of GPs you don't even have to see. You could just ring up and describe your symptoms, and if they were concerned, they'd send you straight to us. At the hospital, at the Nightingale Centre, where I work, and I imagine it's the same at all hospitals, they have the system very well organised. So when you come in the front door, it's quite clear that you should come by yourself to keep numbers down. The chairs are all marked out, so there's loads of social distancing. There are masks at the doorways, there's gel at the doorways, all the staff are wearing PPE, reception has screens up, there is just non-stop cleaning going on, and we have patient safety and staff safety is an absolute priority. And there's 2 reasons why you might come to the clinic. One may be because you've noticed a symptom and you've been to see your GP, or the other one is that you've attended the breast screening unit and you've received a letter saying that they've seen a change and they just want to have a further look. With breast screening, if they want to do a further look, they often usually just need to take further mammogram views, and sometimes then they get a better look and say everything's absolutely fine, or they may actually say, no, you need to have further tests, and that might include a biopsy. So just to give you an idea, of every 100 women who has breast screening, probably about 4 out of 100 would get recalled for further tests. Probably 2 out of 100 would need to have biopsies, and 1 out of 100 would actually get a diagnosis of breast cancer. The other reason you might come to the clinic is, as I say, because you've got a lump. And then what happens in our clinic and most clinics is the first thing that will happen is you'll see the surgeon, and they'll ask you lots of questions. They'll ask you about your family history. They'll ask you about what you've noticed in the breast. They'll ask you about whether you've had any previous breast problems, and also what your general health is like. And then they'll examine you. And then depending on the story and what they find at examination, then there will be further tests. And these tests would include mammogram, particularly if you're over the age of 40, and ultrasound scan, which is very good at looking for targeted areas of concern, like a specific lump you may have noticed. And for our clinic, then, if we see anything we're concerned about, we'd do a biopsy there and then, and we send that biopsy off to the labs. And in our clinic, we get the results back a week later, and at that point, then we can give you the diagnosis, and if it is a diagnosis of cancer, then we can give you the treatment plan. Now, another concern people have during the COVID era is, are we able to deliver safe cancer treatment during COVID? And absolutely we can. We've done a really thorough review of the system across the UK, and we did that review during the peak of the first pandemic. And what we showed was that women were getting timely treatment, they were getting good treatment, and that we are managing to deal with all breast cancers appropriately and on par with how we would have done it before COVID, with the exception of there is a definite reduction in how much we're able to offer breast reconstruction. But absolutely, we are delivering safe care. So it's vital people attend the hospital with any concerns, because if there's one thing we can't do is treat women that we don't see. So if you don't tell us you've got a problem, we can't help you. And early diagnosis means less treatment, and it means more lives saved. So please be breast aware and come and see us. We can help. Thank you.
Thank you, Cleona, for a very interesting talk. If anyone has questions, please include them on the chat and we'll cover them later in the panel discussion. Next, it's my great pleasure to introduce Professor Gareth Evans, who's going to ask the question, how do we predict the risk of breast cancer and why is it important? Thank you, Gareth.
Hello everyone, I'm going to tell you today about how we calculate risk and why it's important in breast cancer. So there are two ways you can assess risk in breast cancer. The first is the risk of breast cancer over time, for instance, a lifetime. We know the lifetime risk of breast cancer is about 12% or 1 in 8 to 9 in the general population over a lifetime. But we also calculate 10-year risks, as these are important for eligibility for extra screening. And also we calculate the chances of carrying a genetic fault, say for BRCA1 or BRCA2. Now, the risk from family history tends to be a little bit exaggerated in that people think, oh, I'm not at risk, I don't have a family history. In fact, only around 4 to 5% of breast cancer is caused by single high-risk genes like BRCA, and only about 15% of women who get breast cancer have a close relative who's been diagnosed with the condition. But when we look at twin studies, about 27%, so between 1 in 3 and 1 in 4, are thought to have an inherited component to them. So when you look at the breakdown of contribution to breast cancer, a bit less than a third is hereditary factors, just a bit over a third is down to lifestyle, and the rest is mainly just down to bad luck. And unfortunately, bad luck does play a part. But these other factors are extremely important in assessing breast cancer risk, and the greatest of those is something called breast density, the density of the breast tissue that we can see on a mammogram. There are loads of other factors, including when you have your period, when you start your family, etc. Alcohol, you'll be pleased to see, is relatively low down on that list, but is a factor. And we assess risk using risk models, and the models that are most used now are Tyrer-Cuzick, which we use in the Family History Clinic, and particularly for genetic situations, we use Boda-CAN risk. So what risks are actionable? In other words, where we would actually take action to either offer or consider various measures. So a high risk is a lifetime risk above 3 in 10, or a 10-year risk of 8% or 1 in 12. And for someone at high risk, we offer annual mammograms between 40 and 60. So that's way more than you get in the general population. And we offer chemoprevention in the form of tamoxifen or anastrozole. And even in this group, we can talk about risk-reducing surgery. Moderate risk, they're at roughly 2 or 3 times the population risk. We are able to offer annual mammography early between 40 and 49. And also consider chemoprevention in the form of tamoxifen or anastrozole. But family history alone only identifies 3% of women, about 1% high risk, 2% moderate risk, who would qualify for these measures. But when we introduce all of the factors in the Tyrer-Cuzick model here, you can see we can populate all these different fields with height, age, mammographic density, etc. We can identify a lot more just on the basis of these factors. And this shows you here, this woman with not a very strong family history of breast cancer, but she easily gets into moderate risk with a 10-year risk of 3% aged 40 and a lifetime risk of about 1 in 4. And you can see her risk in red here to the age of 85 compared to here in blue, the average population risk. So when we look at genes, BRCA1 and BRCA2, pretty much everyone has heard of, but actually they only make up about 20% of the inherited component, and we still got a whole bunch of that inherited component to identify at 45%. But this big slice here is now down to common genetic factors that we all carry that have actually a major influence on risk. So breast density increases the risk substantially and is really important, and is something that we can measure easily on a mammogram. If these two women were 40, for instance, this is a non-dense breast where you see the white is the density. These are the glandular areas of tissue. This woman, age 40, only has a 4% breast cancer risk with no other things considered. This woman on the other side, incredibly dense breast, has about a 25% lifetime risk. So how do we use the common genetic factors? Well, there are now 313 of these SNPs, single nucleotide polymorphisms, that increase the risk. Each one only makes a tiny difference, but when you multiply them all together, it can make a massive difference. So we actually normalize the risk around 1, multiply them all together, and we can end up with risks which are 1/4 of normal or 4 times normal. And this makes a very substantial difference overall to risk. For instance, this is data from Cambridge showing that in women, even without a family history, the top 20% here, this is divided into what we call quintiles. This is the top 20%. These are actually moderate risk with a lifetime risk of 17%. And the bottom quintile are at about half of the population risk here. So the bottom 20% only around a 5% lifetime risk. And this bottom quintile actually never gets to the average risk that is required or intended for women to get breast screening, which is about a 2.4% 10-year risk. So we have done a lot of work on this using data from our PROCAST study in the Greater Manchester, 58,000 women, and we've also got 10,000 where we've collected DNA, so we can use density, DNA, and standard risk factors. And this shows you the distribution over of 10-year risks for an individual. And we have, as I say, now got over 600 prospective cancers in the 10,000 that we collected DNA on. And we've genotyped that for 143. We've now done 313, but I'll going to present the 143 SNPs and including the density. And this is a bit of a busy slide, but what it shows here is in the green is the combined analysis showing you that there's 20% of women here that have a risk above 5%. That is moderate risk here or high, and actually 45% of the cancers here are actually captured in this 20%. So nearly half of the cancers are found in about 1/5 of the population. On the other end, you can see many more women pushed down into the low risk, below 2% in the green, but much fewer cancers. So only 7% of the cancers in nearly 20% of the population. And there is a big change. You can see in blue is just the standard risk factors here. Most women in the average risk group, many more women pushed down into low risk, which is good to know. And quite a few more into this high risk group, which is actionable, that we can do something about. So what I hope I've been able to show you is that we are now able to really calculate risk very well on a population basis. It's not just about family history, that these common genetic variants are much more useful even than doing BRCA testing and everything else, which is only informative of about 1 to 2% of the population. And it's important to identify this 1 in 5 women who are eligible for extra screening and preventive medicines. We can reduce the number of breast cancers and also pick those that do occur up at an earlier stage. It may be important as well for identifying those who don't need as much breast screening. So I'd like to thank many, many people, radiologists, colleagues, particularly Tony Howell, who we jointly sort of push this through for all the work that they have done. Thank you very much.
Thank you, Gareth, for that stimulating talk. If anyone has any questions, again, please put them on the chat and we will cover them later in the panel discussion. Next, I would like to introduce Dr. Sasha Howell, who's going to ask the question, what type of clinical approaches can be used to prevent breast cancer? Thank you, Sasha.
Hello, my name is Sasha Howell, and it's a pleasure to talk to you today about the type of clinical approaches that can be used to prevent breast cancer. I'm a senior lecturer in medical oncology at the University of Manchester, and I work here at the Christie to treat breast cancer, but also at the Nightingale Centre, where we run family history, risk and prevention clinics. So what are the approaches that we can use? Well, what I'm going to talk to you about today is drug treatments, so tamoxifen, anastrozole and raloxifene. But it's also important to remember that lifestyle is very important in breast cancer risk, so obesity, alcohol reduction, increase in exercise, and also surgery can be used in those at higher risk, so risk-reducing mastectomy. Both lifestyle and surgery will be discussed at future MBC educational days, but we're going to focus today on drug treatments. So where did breast cancer preventive therapy come from? The answer is breast cancer treatment trials. So when a tumor develops in the breast, such as this cartoon on the left, surgery, radiotherapy, chemotherapy are commonly given. And then from the 1970s onward, tamoxifen was tested in clinical trials and at increasing duration. So first trials of 1 year versus nothing, then 2 years, then 5 years, and now actually we're up to 10 years. And what that showed was that tamoxifen was successful at reducing rates of breast cancer recurrence, but also death from breast cancer. And the more effective, it was more effective the longer it was used. And there was a critical observation that breast cancer in the other breast, so we know that when you've had breast cancer in one breast, you can develop it in the other. It's not that common, but it does happen. But with tamoxifen, there was a significant reduction in the amount of breast cancer, or the number of breast cancers in the other, what we call the contralateral breast. And so you can see on the graph at the bottom, 1 year of tamoxifen treatment reduced the risk of breast cancer in the other breast by around about 10%, 2 years by about 20 to 25%, but then 5 years of treatment, which has become the gold standard treatment duration, is now, reduces the risk by about a half of developing breast cancer on the other side. So from there, what we call primary prevention trials followed, so multiple studies in women at increased risk of breast cancer. So these are women, for example, that Gareth Evans has already discussed about how we identify those at increased risk. And over 60,000 women have been involved in those studies over a 25-year period. And the results show that tamoxifen reduces the risk of breast cancer by around about a third, 30 to 40%. So in this pie chart on the right, if everyone were to develop breast cancer in blue, then with 5 years of treatment, the pink is no cancer, here about 35% reduction. Whereas with anastrozole, this reduces the risk of breast cancer by a half, but is only available for women who have gone through the change because of the way that it works. So for postmenopausal women, anastrozole reduces the risk of breast cancer by around about 50%. And importantly, the risk reduction from these drugs lasts after the treatment is stopped. So here's a graph from the IBIS-1 study. On the left, we've got the percent of women with breast cancer, and on the bottom is the years since the treatment was started. It goes up to 20 years. I've drawn a red dotted line here that shows you the 5-year treatment course. So the treatment with tamoxifen was only during this period on the left, and you've got the women who were unfortunately diagnosed with breast cancer here on the placebo in blue, and the number that were diagnosed with breast cancer here in red with tamoxifen. And you can see that from the point that the treatment stopped, the curves continue to separate and go apart. So this looks like it may well be a lifelong effect of tamoxifen just from a 5-year period of treatment. So what drugs are now recommended by NICE? NICE is the National Institute of Healthcare and Clinical Excellence. For premenopausal women, there is only tamoxifen. And we recommend that for a 5-year period for the reasons that I've just explained. For postmenopausal women, anastrozole is recommended unless a woman has thinning of the bones called osteoporosis. And in that situation, we would use raloxifene. It isn't quite as good as anastrozole at reducing the risk of breast cancer, but it's also a treatment for osteoporosis. So if you like, you get a double whammy by using raloxifene in that setting. If we look at the cost-benefit analysis that NICE did when they were looking to approve anastrozole, and if we take 1,000 women treated, we know that we will see 35 fewer women developing breast cancer. And in terms of the incremental cost to the NHS, it is minus 35,000. That means this is cost saving to the NHS by using anastrozole. Anastrozole is a very cheap drug now. It costs just a few pounds to treat for a 5-year period. And we estimate there are around about 1 million women aged 50 to 64 who are at least moderate risk of breast cancer who would be eligible for anastrozole. If they all took it, there would be 2,000, in fact more than 2,000, fewer breast cancer cases a year, and that would save the NHS £2.3 million a year. So this is a very good treatment which will reduce not only individuals getting breast cancer, but will be cost saving to the NHS. Of course, there are some downsides, as there are with any drug treatment, and there are some side effects. So for example, here for tamoxifen, this can cause hot flushes, night sweats, and it can cause vaginal discharge. And in terms of the hot flushes here, which is the commonest side effect, the way that we represent these data is to show that the women who already have some hot flushes, so these would be women entering or gone through the menopause, in pink here already have some hot flushes. In purple, we see the women who have developed those hot flushes because of the tamoxifen treatment. But perhaps most importantly, we have women over here in the grey bars who don't have any hot flushes either at baseline or after they have started tamoxifen. So a lot of women don't have any side effects from these treatments. And I think that that is an important bit of information to get out there because they have a rather bad press currently. There are some uncommon but serious tamoxifen side effects. It can cause blood clots. So there's one extra case per 500 women treated. So it's an uncommon side effect. And it's more likely in those that are overweight or immobile. So again, we need to personalize the treatment of all of our patients when it comes to making decisions as to whether this is the right thing for them or not. Tamoxifen can also cause a cancer of the uterus. And of course, that's not something we want to do. We're trying to reduce the risk of a cancer and not cause another one. But this is only in postmenopausal women, which is why anastrozole is preferred for postmenopausal women, because it doesn't cause either of these side effects. Anastrozole can, of course, cause some problems of its own, some hot flushes, joint aches, vaginal dryness. But looking down this column on the right, this is the number in addition, so the purples, if you like, from that tamoxifen graph I showed you, who develop it, and it's a relatively small number that develop an increase in these side effects. And actually there are some beneficial side effects of anastrozole in reducing vaginal prolapse, itching, and other cancers. What's important, I think, for looking forwards is that we can work out who is benefiting from treatment. This is still experimental work currently, but what we know is that in those that get a reduction in their density, on the top two bars on the left, are more likely to get a reduction in incidence of breast cancer than those where we don't see any change in the breast density. And on the right here, we've done some work looking at MRI enhancement. And again, with tamoxifen, we see this drop in enhancement in the breast. And we're hopeful what this will give us is a biomarker to show which women are getting benefit and should therefore continue treatment, as opposed to those where we don't think there's going to be a benefit, and therefore we can save them the 5 years of possible side effects that I've just been talking about. So in summary, drugs used to treat breast cancer can also prevent it from occurring at all. Women at increased risk are eligible and should have preventive drug therapy discussed, and tamoxifen and anastrozole can reduce risk by up to 50%. The side effects are often minimal and they are reversible if not. So it's worth just giving the drugs a go, in my opinion. And this is cost saving to the NHS, and in my opinion, should be applied more widely. Thank you very much.
Thank you, Sasha, for the talk. If anyone has questions, please include them in the chat and we'll cover them in the panel discussion later. Next, it's my great pleasure to introduce Professor Charles Stroily, who's going to tell us about what the benefits of breastfeeding are. Thank you, Charles.
Good afternoon. I'd like to talk to you today about how breastfeeding your baby will protect you against getting cancer in your later life. So for the mother, as I said, breastfeeding protects against getting breast cancer. So if you feed your youngster when you're in your 20s, 30s or 40s, that leads to cancer protection in the age of 60s, 70s or 80s. So how does that work? There are other benefits of breastfeeding as well. So one is that breastfeeding acts as a contraception, and another is that it has really medically important benefits too. It can get less ovarian cancer, less diabetes, less heart disease and stroke. So all round, breastfeeding is great for the mother. It's also good for the baby. So actually, breast milk is perfect human baby food. Remember that formula is made from cow milk, and that's great for baby cows, but it's not ideal, in fact, for human babies. So far better food if you breastfeed. A second reason that babies benefit from getting breast milk from their mother is that mother's milk contains antibodies that she's raised against all sorts of diseases, and they pass into the milk and they'll help the youngster not get so many diseases while your baby is in the first few months of life. For example, gut diseases are protected by mother's milk. In later life, babies who've fed from their mothers will have less diabetes, less heart disease, less obesity. And overall, breast milk saves the lives of getting on for 1 million babies worldwide each year, which is quite amazing, really. Of course, if a mother breastfeeds, then there is a particular type of mother-baby bonding that goes on, and that actually lasts for life. So, unfortunately, in this country, the UK is the world's worst at breastfeeding. So here's a map of the world, and in Africa, South America, India, many parts of the world that are marked in green here, there's lots of breastfeeding goes on. An awful lot of mothers will breastfeed for up to a year. However, that's really not the case in Europe and in the States, and we are actually the worst. So the government recommends breastfeeding for at least 6 months, but actually only 3/4 of mothers start to breastfeed, and less than half are breastfeeding at 6 weeks, and that's down to 1/3 by the time a baby's 6 months old. But even then, only 1% of babies are exclusively breastfed up to 6 months. Well, we're mammals, and all mammals make milk to feed their young. In fact, when you're in full flow, then you're providing your baby with about 1.5 litres of breast milk a day. And in other animals, some are much bigger. You know, for example, a blue whale is a mammal, and it feeds its babies 250 litres a day. Is that we need to increase the proportion of mothers who exclusively breastfeed for 6 months. We need to improve the knowledge about breastfeeding at school. We need to develop breastfeeding awareness campaigns. There needs to be medical, family and societal support. And also, I think, for the first 6 months of having a baby, there needs to be paid maternal leave in order to be able to do that. Maybe one possibility is to actually legally ban babies from getting formula until they're 6 months old. Let me tell you how your breast develops and how it makes milk. So here's an image of a human breast. There are lobules here, blown up here, and these are the milk-making bits. So your lobules grow during the menstrual cycle and in pregnancy in response to signals from estrogen and progesterone. And of course, there are lots of local growth factors as well that contribute to the growth of those cells. And as you get towards having a baby, then you begin to make milk. And there are signals that are provided by a circulating hormone called prolactin, and also from the three-dimensional structure of the breast. And what actually happens is that these cells here, these are the lobular epithelial cells. They're the milk-making cells. There are blood vessels around here to provide nutrients. And these cells make milk and secrete it here into the lumen of the lobule. And then what happens is that when the baby suckles on the nipple here, that sends a signal called oxytocin, which makes these myoepithelial cells that surround the lobules contract, and it squeezes the milk out of the lobules into the ducts. So here's a higher power view of a duct. It's basically a tube, and the milk flows down to the nipple here, where the baby gets all of its food. So that's how the breast works. And I wanted to tell you about the timeline of lobular growth. Well, lobules in your breast grow in the menstrual cycle. If you don't get pregnant, then those cells that have grown become removed. And women start to menstruate in their early teens, and everyone will have about 500 menstrual cycles in your lifetime. If you get pregnant, well, the lobules grow. They don't completely fill up the breast by the time you have your baby. There's lots of cells there, lots of lobules, but if you don't breastfeed, they get removed, just the same as they do in the menstrual cycle. However, if you lactate, you start to breastfeed your baby, you breastfeed for 6, 8, 9, 12 months, the breast fills up completely with lobules in the first few weeks, and then it keeps going and makes all this milk. And when you stop breastfeeding, the tissue weans. And there is massive tissue loss and cell loss and tissue remodeling that occurs in order to prepare the breast for the new cycle that it will have to go through if you get pregnant again. So it's this massive cell loss which is crucial. Let me tell you about breast cancer. And what actually happens is that one way that breast cancer starts is that stem cells are altered. Well, first of all, let me just tell you about mortality in this country. Here's age, and here's the number of deaths that occur. And breast cancer really gets going, mostly in your 50s, lots more in the 60s and your 70s and 80s. And in this country, 11,000 people a year die from breast cancer. That's 31 people a day. And this number's been about the same for at least 30 or 40 years. Well, what are the reasons for getting breast cancer? Well, first is getting older. Another reason for getting breast cancer is that when you go for a mammogram, you can be told if you've got high breast density, medium or low breast density, and if you've got high breast density, that's about 5 or 6% of people, then that's a high risk factor for getting breast cancer. If you get too heavy, you become a beast during your 20s, 30s, and continuing from that, then that's a risk factor. And those people who do night shift work also have a higher risk of getting breast cancer. Early menarche, late menopause also contribute. That's because you have more cycles. And the key thing that I'm talking about is not breastfeeding is a reason for getting breast cancer. Well, in the breast, you've got stem cells. Now, stem cells are precursor cells for all sorts of tissues. You've got stem cells in your skin, they'll make skin cells. You've got stem cells in your gut, they'll make gut cells. And you've got stem cells in your breast. And they're the precursor cells for making all of the cells in the lobules of the body. And they arise when your breast develops. So, what actually happens in all your cells is that you occasionally get mutations. Now, most cells are not stem cells, and they'll eventually disappear, so that's okay. But stem cells stay there forever. And occasionally, you get mutations. And maybe every 4 or 5 years, there'll become a mutation, and you'll get them from your early teens way up into your 60s and 70s. And if there's a combination of mutations that occurs, sometimes those mutations can cause cancer. Now, during your menstrual cycle, those stem cells will remain. They don't disappear. There's a bit of growth, a bit of cell death or cell removal, but the stem cells stay there. And the tissue grows, your breast tissue grows when you're pregnant and up to childbirth. It's not fully developed yet. And if you decide not to breastfeed, then all those new cells will disappear. However, under those conditions, the stem cells also remain. But if you fully lactate, then your whole tissue becomes completely full of breast cells, and they're producing milk for 6, 7, 8 months. But when the baby stops breastfeeding, that tissue implodes, and it really undergoes a completely catastrophic change in order to prepare you for the next pregnancy. And at that time, many stem cells also die. So some of that cells that would have had mutations, quite a lot of those cells are got rid of. And of course, that reduces cancer risk in later life. In fact, you have a reduced risk by about 4.5% for each baby that is fed by my mother for 6 months, followed by a mixture of breast and formula for the next 3 to 6 months. So all of what I'm telling you is really saying, well, if you're a youngster and you've got a brand new baby, then breastfeed, because that will protect you from getting breast cancer. It will protect you from all sorts of other things as well, and it's good for the baby. And as mammals, in fact, almost all mothers are completely able to breastfeed their babies. There are no real issues, and it should all work. So good luck, and thanks for listening. Bye.
Thank you, Charles. If anyone wants to discuss this further, please include your questions in the chat and we will cover them in the panel discussion that we're going to hold right now. So I'd like to hand over now to Dr. Ahmet Ukar, who will lead the panel discussion. Thank you very much for listening to the talks. Bye.
Thank you. Thank you very much, Rob. Before we start our panel discussion, first, I would like to thank all our speakers of the day and the charities who have been supporting this event, as well as our research. I hope that you have found these talks informative and beneficial for yourselves. I am also glad to announce here that we are recording this virtual event, and the recorded file will be made available by next week on the homepage of Manchester Breast Centre that you see over there, and the YouTube channel of the Manchester Cancer Research Centre. If you know anyone who has missed the opportunity to attend for today's event, please let them know that they can still watch today's event later in the internet. Breast cancer is a devastating disease for our society and worldwide. As you have heard from Charles, there are 31 women who are dying from this disease every day, just in the UK alone. What makes breast cancer a big health problem for the society is actually its very high incidence levels. As you have also heard earlier in the talks, 1 in 8 or 9 women develops breast cancer at some point in their life. Although the number of people dying from breast cancer in each year remains more or less similar over the last 30 to 40 years, This is despite the increase of the population size and the increase of the age average of the human population. As a matter of fact, the age normalized death rate, which is the number of deaths per 100,000 people, has been steadily declining in the last 30 years, as you can see in this graph. Starting from 1990s, we see this decline. This is indeed the case for all age groups that are in their 50s, 60s, and 70s, which are shown on this graph in blue, orange, and gray. What is also interesting to consider is the impact of breast cancer on different generations. Although this graph is a little complicated as it's a three-dimensional graph originally, but what it actually says is you are less likely to die of breast cancer compared to your grandmother or mother. And it's also likely, and hopefully, that your daughter will be less likely to die of breast cancer compared to you. And this is all because of the developing new treatments for breast cancer. And for all these improvements, we need to be thankful to the success of breast cancer researchers around the globe for developing various treatments that are available now in the clinics. Breast cancer research in Manchester in the past and at the current time have an enormous contribution to this success. Many of the treatments that are currently used in clinics has actually been developed in Manchester in the past. However, our efforts and hard work will continue further till we can reach the day that no lives are lost to breast cancer. Manchester Breast Center is the biggest research organization in the world in terms of number of research groups working exclusively on breast cancer. Our research addresses all aspects of breast cancer, including prevention, early detection, and new treatments for both primary and metastatic secondary breast cancers with a focus on personalized and precision medicine. The vision of Manchester Breast Center closely aligns with the visions of our supporter charities. Similar to the Prevent Breast Cancer, we would like to improve our prediction, prevention, and early detection methods for women who are at increased risk of developing breast cancer. We also share and contribute to the vision of Breast Cancer Now, which is by 2050, we want everyone who develops breast cancer to live and live well. Essentially what this means is people who are born in this millennium are less likely to die of breast cancer if we achieve this aim. And people who are born now will not have the fear of dying of breast cancer if we will achieve this vision. We know that the only way we can achieve these ambitious aims is by supporting breast cancer research in order to find better methods to prevent, to early detect, and to provide patient-centered personalized treatment options for those who have primary or secondary breast cancers. To do so, we need to recruit the brightest minds in the world to breast cancer research so that they can develop the best new ideas going forward. And we need to fund their research to test those ideas and bring new discoveries from bench in the labs to the bedside in clinics. And finally, we also need to train the new generations of highly skilled researchers, clinicians, and nurses. Indeed, this is what our supporter charities do every single day with their hard work around the clock. They raise money from public through donations and fund the life-saving breast cancer research. They lobby at the top of the healthcare system and in the parliament to provide the best there is for our patients. In this regard, I would highly encourage all of you to visit their web pages and learn more about them. I would also encourage all of you to provide generous donations to these charities in order to support the top-ranking, world-beating breast cancer research in the UK. And don't stop there. You can all volunteer or participate for their various fundraising events taking place all around the year. Especially now, during these difficult times due to the ongoing COVID-19 pandemic and lockdown restrictions, which unfortunately negatively affect all fundraising efforts of our charities. Please show your support and make yourself to contribute in achieving a brighter future where no one dies of breast cancer and anyone who develops breast cancer to live well. Well, with that being said, I will now start our panel discussion. Our panel members include professors Rob Clark, Gareth Evans, Cleona Kirwan, Charles Trulli, and myself as the moderator. We will first address the questions we have received from you in advance of the event, and then follow with the questions you have been submitting during the event. Okay, can we bring all our panel members' videos on, please? So we did receive several questions that has been submitted in advance, and we'll answer 3 of them with our panel members. So the first question comes from Boniface Kasoli from Kenya. Can use of family methods, family planning methods, such as long-acting reversible contraception, such as the implant or intrauterine device, or hormonal contraception, such as the pill or Depo-Provera injection, be a risk factor for a woman to suffer from breast cancer in later life? So I think among our panel members, we could ask Gareth. Gareth?
So yeah, there is some evidence that contraceptions do increase the risk, but that risk tends to be transient. So for instance, the best evidence is for the combined oral contraceptive, where you have about a 25% increase in risk when you take it, but that disappears after about 2 or 3 years. So to put it in perspective, when that tends to be used is in your 30s. If you were at average risk with no family history and you used the pill for 8 years from the age of 30 to 38, the average risk is about 0.5%, about a 1 in 2 in 1,000, 5 in 1,000, so 1 in 200. You would only have a 1 in 1,000 extra risk of developing breast cancer. However, if you were a BRCA carrier, you would actually have a 4%, 1 in 25 extra risk. So we don't advise women with strong family histories or who are BRCA carriers to take the pill after 30. But if you don't have risk factors, then there really isn't a contraindication of taking the pill. The evidence for progesterone is a lot less, but there probably is an increase also, because actually progesterone is probably more the culprit than estrogen, but they actually work together to increase the risk. But both of those risks appear to be transient, and as the risk is small when you are young, then the extra risk is also small.
Great, Gareth. And actually the other part of the question is the non-hormonal contraception. So for these people who are having high risk, instead of pill, can we actually advise intrauterine device as a contraception method?
So all of the intrauterine devices are fine. There is some evidence that the Mirena coil, which includes progesterone, that there is, in some women at least, a little bit of circulation. It goes into the circulation. It can occasionally cause, things like bloating in women. So some women do get a little bit of progesterone into the circulation. So it may slightly increase the risk, but only while you have it in.
Great, thanks. Our second question is from Jane Hudson, who is, I believe, in the audience as well. Yes, it's quite a long question, but I will try to summarize. Jane has a C5-6 tetraplegic, so she's with a wheelchair. And she was asking that it's really difficult to get a mammogram if you are bound to the wheelchair. So the question actually is whether there's a preventative testing or diagnostic equipments that are available also for disabled people, And if not, are there other methods that can be used instead of mammograms? I believe Cleona will be the best suited person to answer. Cleona?
Yes, absolutely. Well, the only fully validated way of doing screening in a normal population is with mammograms. Now, in general, breast screening units are very well set up to deal with more difficult situations, people who have struggled with mobility. And also it's worth contacting the breast screening unit, because it may be that there's better facilities at screening units based in the hospital, such as the Nightingale Centre, rather than the vans where there's less space. So it's always worth contacting the breast screening unit directly. But we don't have any other systems within the NHS breast screening programme for routinely screening people other than mammogram, unless they are at increased risk, unfortunately. However, as always, it's absolutely key to be breast aware, to examine breast carefully, and if you did have any concerns or symptoms, then ultrasound scan can be very good for when we're looking at specific areas of the breast, and then you can do very diagnostic, very focally directed tests to look at the breast.
Well, maybe we should also promote the policy change of providing extra treatments or modified equipments for people who are disabled.
But they'd have to be validated. So all of these have to be validated. And it's because what you don't want to be doing is saying, oh, great, you've now had your screening test, but actually it's not that good. So a patient is falsely reassured. So it's absolutely, you know, anything like that has to be validated, because you've got to be very cautious about over reassuring people.
Yes. There is one question from our chat today, Sami Al-Janabi. It's actually quite an interesting topic, because when we talk about breast cancer, we always think of the women. However, men can also develop breast cancer, although it's around 100 times lower in instance. So Sam is asking, especially for Cleona, whether the self-examination and detection of potential breast cancer in men, similar as women, can men also do self-examination, or is completely different because of the different tissue composition? Cleona?
Brilliant question. So first of all, to put male breast cancer in context, male breast cancer clearly does exist. There are probably about 370 men per year diagnosed in the UK with breast cancer, as compared to 55,000 women diagnosed in the UK with breast cancer. So it exists, but it is very rare. Men have breast tissue that is localized really to the nipple area. So if a man was to get breast cancer, it's likely to develop at the nipple, or if it's spread, then it could present as lymph nodes in the armpit. So what a man would be looking for would be realistically a hard lump or skin changes of the nipple area, or else a lump in the armpit. There is some evidence to say that survival in men with breast cancer is ever so slightly lower than survival with women in breast cancer. And we don't know why, because in some ways men can present earlier than women, because a lump in a man's chest wall is likely to be felt easier than if it's at the back of a very large breast in a woman. But it may be that men just don't recognise a lump as a worrying symptom, and therefore present later to the doctor. Now, if someone does come to our clinic with a breast lump, we absolutely can perform mammograms and ultrasound scans, and they're incredibly effective in men. And then if we've any concerns, we would do biopsies as well. So the management would be very similar as with women. And actually the treatment is very similar as breast cancer for women. The only challenge with men is because it's such a rarer disease, there's less research about male breast cancer compared to female breast cancer. So the evidence base for managing female breast cancer is enormous and of hugely high quality, but that's less true of male breast cancer. So we presume a lot.
Yeah, I guess a good advice for all the men is, if you feel a lump around your nipple area, do not ignore, just see a doctor.
Absolutely. I mean, gynecomastia or innocent breast swelling is incredibly common, But if anyone is of any doubt, see the GP, and the GPs have very low thresholds for referring people in. So, you know, if you don't know, ask.
Great, thanks, Cleona. We have an interesting question also from Rebecca, and I guess we can bring in Gareth and Rob. Would you recommend tamoxifen for BRCA1 positive people who didn't want surgery, and from what age?
Do you want me to answer that, Rob? Or?
Yes, please. I think you're better qualified than I am.
So the problem with BRCA1 is that 70% of the breast cancers are estrogen receptor negative. And the evidence is tamoxifen doesn't prevent or doesn't reduce the risk of estrogen receptor negative breast cancer. And so while there is a little bit of evidence that tamoxifen may work a little bit in BRCA1, it probably reduces the risk by less than the 30 to 40% that Sasha discussed. So I would think maybe only a 15% reduction. And for many women with BRCA1, that really wouldn't be enough. So if you were going to give it, you'd probably start giving it even as young as 30, but obviously women couldn't get pregnant while they were on tamoxifen. But for BRCA2, it should work extremely well because the great majority of breast cancers with BRCA2 are estrogen receptor positive.
Great. Do you have anything to add, Rob?
No, I think Gareth has covered that well, I think. Unless, if anyone has further questions, please put them on the chat and we'll try and address them.
Great. There's one about letrozole.
Yes, that's what I wanted to come, Gareth. So do we...
Yeah, so yes. So what about letrozole? So letrozole, like anastrozole and like another drug called exemestane, are all aromatase inhibitor drugs. So they work by stopping you producing estrogen after the menopause from your adrenal glands and your fatty tissues. And the problem with this is that anastrozole was the only drug that was tried in the right group of women, that's women without breast cancer, to be able to prove that it worked, and it worked better than tamoxifen. So that was in the IBIS-2 study. So NICE have only approved anastrozole and not letrozole or exemestane. So they are both likely to work. Exemestane, there was a different trial, but it wasn't in unaffected women. They are both also likely to work and probably work as well, but anastrozole is the drug that was actually used in the trial and has been approved by NICE.
Great, thanks. There's also a question for Charles from Farideh Jalal. Do you recommend 2 years long of breastfeeding instead of 1 year? Is there an additional advantage?
Not to my knowledge, no. I think that most women, if they're going to breastfeed, will feed for 6, 7, 8 months, probably until those little teeth come in and it becomes a little bit of a painful experience. But there are plenty of women who continually breastfeed for 1 year. I don't think it's going to make much difference whether you do or don't breastfeed after that. Once a baby is getting to be about a year old, they'll be getting solid food anyway. So I'm not sure that going beyond 1 year makes much difference, really.
Great.
It might make a difference to your breast cancer risk. The evidence is that that in sub-Saharan Africa, women who breastfeed continually, virtually for 12, 14 years, do very substantially reduce their risk. So it's 4.5% reduction per year of breastfeeding. And that doesn't matter if it's the second or third year, it still reduces the risk. So it would only work for breast cancer risk reduction, wouldn't necessarily be of benefit to the baby.
Great. There's also a question that has been sent on the private chat. This for Gareth, directed for you. I will just be reading it. I'm over 70 and here the screening is paused currently. I know the great importance of screening in my age group. Will my risk increase just because I'm not being screened? Patricia also had breast cancer 21 years ago.
Right. So screening hasn't stopped. It is going on, but it's only going on at about 50% capacity at the moment. And if you're over 70, you actually have to request screening. So you actually have to request it rather than wait for the invitation. You make, unless you're in the age trial, that is, of course. Cleona wants to put a hand in the air.
Sorry, at the latest update, because of the COVID, even though we've reintroduced the screening program, it's pared down. So there was an age extension trial where we were screening from age 47 to age 73. That's temporarily paused. So we're very much sticking to the tight window of 50 to 70. And women are getting sent letters and they have to arrange their own appointments now rather than being given appointments. But the other thing was ladies over 70, pre-COVID, could ring up and book a screening appointment up until whatever age that they wanted. So they weren't being sent for by the breast screening program, but could book an appointment if they wanted them. And unfortunately, at the moment, that service has also been stopped because they're trying to prioritise the classic breast screening age, unfortunately. So I think that just means any woman over that age group, if they have any symptoms, see your GP and come in and we will assess you that way. But we're sort of relying on you coming with symptoms. But hopefully we'll get things back to normal as soon as we're through this little hump.
But just to clarify, you're not making yourself more at risk. Having breast screening doesn't reduce your risk of breast cancer. It just picks it up earlier. And someone who's had breast cancer and had treatment to one side, if it's radiotherapy or mastectomy, the main risk is on the other side. And if you've had tamoxifen, for instance, that halves the risk. And so you would be at no more risk in your one remaining breast than the general population. If you haven't had tamoxifen, you would actually be about double the risk of the average woman in two breasts.
Great. There's a very interesting question from Rebecca, and there were some recent research about it as well. Is it worth for a BRCA1 patient or woman postponing risk-reducing surgery in order to breastfeed, or does it not lower the risk enough to wait?
So there are, it's a difficult one, but in an ideal world, you'd have your children extremely young. In your early 20s before the risk kicks in, and then breastfeed and get the benefit of that. But the problem is that once you're into your 30s, and often women nowadays are having their children in their 30s, then the problem is that that's a time when you should be having MRI screening. We can't MRI you while you're breastfeeding. So if you want to breastfeed for a year, and you're pregnant for 9 months, that's nearly 2 years that we can't screen you if you're a BRCA carrier. So that is a bit of a concern. That so we don't actually suggest very long breastfeeding in BRCA carriers for that reason. Ideally, you should have your MRI scan just before you get pregnant. You can't always plan that. So you're as sure as possible before you're pregnant that there's nothing there. And then probably because of the issue of detecting the cancers, and you're in that higher risk period in your 30s, probably not to breastfeed for a long period of time. But I'm not sure that a 4.5%, 9% for 2 years breastfeeding is enough reduction for many BRCA carriers to not have surgery. So certainly if you're thinking about not having surgery, then have everything that can help your risk. But I'm not sure that a relatively small overall reduction will be enough for about the 50% of BRCA carriers who choose to have risk-reducing mastectomy.
Thank you. To follow on that, we got another question on the private chat. What about being pregnant at late age? Does it increase the breast cancer risk?
I'm afraid it does. So the evidence, it's one of the big risk factors, I'm afraid. So having your first pregnancy at 35 compared to 18 to 20 is more than a doubling of risk. So it is a big risk factor, and actually having children late is worse than not having children at all in terms of risk. So it sort of tips at about 30. You get protection before the age of 30 for having your first child. After 30, it starts to rack up. So the later you leave it, unfortunately, it does start to push the risk up. And that is one of the many reasons all of the risk factors, pretty much all of the risk factors for women have gone up in the last 60, 70, 80 years. Women start their periods earlier. They have their children later. They have fewer children. They don't breastfeed as much. I shouldn't be saying this. It should be a woman saying this. Unfortunately, weight is an issue, and weight gain is a big problem for later breast cancer risk. And then obviously there is a bit of a risk from HRT. So all of those things have gone in the wrong direction, probably less exercise as well. So, you know, the risk of breast cancer has gone up hugely due to lifestyle factors, hormonal factors that are potentially modifiable, but it's hard to modify them once you're 40 and you haven't done what, you know, was necessary. And you can't really organize your entire life around when you have your first child. You know, may not be possible.
Yeah, Gareth, we heard from Charles that breastfeeding modifies risk in a beneficial way. Would that still modify the risk beneficially if you were having your children late?
Yeah, it seems to. It still seems to have an effect.
So it's
and
still
even
breastfeed if you have a child in your you know, mid to late 30s is
yeah, it still seems to have some benefit. So there's no evidence that the breastfeeding benefit disappears if you're having your first child older. But unfortunately, you're increasing your risk by more than the breastfeeding is going to bring it back.
Okay, but there's still some benefit.
There's still some benefit.
Good.
Great. We have another question from Arminia Romano. Is there a link between having papillomavirus and chances to develop breast cancer? Anyone who would like to come up to answer?
There are some papers on it, but they're not very convincing. I'm really not convinced by the stuff that's out there, but certainly there is no compelling evidence that papillomavirus increases breast cancer risk.
So there's, you know, historically been a lot of interest in whether viruses might be causative in breast cancer because, you know, that has been shown in other animals. But yeah, there's no, I mean, there have been some viruses found in cancer tissue, but that does not indicate that they were causative. You know, it might just be that they have occupied that tissue because it's highly proliferative. So I think, you know, there's no evidence of an infection causing breast cancer. It is my interpretation of all the data. And, you know, it's very obvious in some other cancers like cervical cancer and liver cancer that there's a viral agent. So it would be a surprise if there is a viral agent and it hasn't been discovered in breast cancer. That's my interpretation, you know.
I agree
we
with
will
you.
be surprised.
Great. We have one more question from Judith Füle. Should complex cysts be removed or biopsied? These are pre-malignant stage, I believe. Cleona?
A straightforward cyst normally would be if aspirated purely for symptom control, because the diagnosis is very straightforward on ultrasound scan. If there was any diagnostic doubt, then a biopsy would be performed, and under ultrasound you can target that biopsy to sort of abnormal areas of a cyst wall if you had any concerns. in terms, and fundamentally it depends, it's individual, it depends on every individual case, weighing up the imaging and biopsies and any cellular changes that you see on biopsy. We wouldn't routinely remove a cyst without having biopsied it first, but to be honest, you stick a needle in a normal cyst, it disappears and you've cured it.
And we can keep it you, Cleona. Becky Darlington is asking, is there a link between fibroadenomas developing into breast cancer?
Great question. And no, there isn't. The only thing is fibroadenoma is made up of breast tissue. So I have seen a cancer develop in a fibroadenoma because a fibroadenoma has breast tissue in it, but it is not a risk factor for breast cancer, which is why. So for people who don't know, fibroadenomas are very innocent lumps that can develop in the breast. We call them a mouse because when you examine them, they've got very smooth edge to them. They're quite firm, a bit rubbery, but they move around in the breast. They feel very mobile. And they classically something that you see in 20-year-olds. They can get bigger with your period, they can get bigger when you're pregnant, and they seem to at some point usually disappear. But sometimes in mammograms, you see little white balls where these fibroadenomas have calcified. We often, depending on a woman's age when she presents, we often biopsy these just to confirm that they are fibroadenomas, and we wouldn't recommend removing them because usually you can't see them. So why swap something you can't see for a scar that you can see? So we don't routinely remove them unless they were particularly large and having a cosmetic impact. So we just leave them well alone once we're certain about the diagnosis.
Great. There is another interesting question as we are getting more and more into machine learning. So Farida is asking, have you used any machine learning methods for prediction and early detection of the breast cancer? And what's the chance of multimorbidity for the patients with the breast cancer? Who would like to take the question from our panel members? Rob?
I'm thinking machine learning and Sue Astley.
Yeah, I'm not sure I'm qualified for that one.
Yes, essentially in Manchester Breast Center, we have research groups who are working on this, especially trying to have better diagnosis or predictions using mammogram pictures, and they use artificial intelligence method. However, Sue is not here, but in the next upcoming public engagement events, we will also cover this issue. So we have quite many questions coming, but there was one of the questions that was submitted in advance from Joe Taylor, and I guess this already triggered a lot of discussion prior to the event. So can you really prevent breast cancer? It's open for all panel members to comment.
Yeah, we've been privately discussing, I think some of it's semantic and some of it is what we might medically or professionally mean about prevention of breast cancer and what it means on an individual basis. So we can reduce the risk in populations of developing breast cancer, but for an individual, can we say that we've prevented a breast cancer? I mean, that would be quite difficult to prove. If we treat 1,000 women at risk of breast cancer with an anti-estrogen such as tamoxifen, Sasha has shown you that you can reduce the population risk by 50% after 5 years of tamoxifen. So you could argue you're preventing 50% of those breast cancers, but for the other 50% who still get breast cancer, you haven't made any prevention at all. So, but you've reduced the risk of the whole population. So, yeah, I think and that might, you could use that kind of modeling for any of these factors that contribute to risk. While you can reduce the risk, it's quite hard to eliminate it. I mean, risk reducing surgery is pretty effective in eliminating the risk in BRCA mutated women. But I mean, that's by removing the breast tissue. So, I mean, that is effectively reducing the presence of breast cells. So yeah, so this prevention versus risk reduction is something that can be debated.
Yeah, it's very, as Rob says, it's impossible really in almost every situation to say in an individual woman you've prevented breast cancer, but we can substantially reduce the risk. And the obvious example is in BRCA carriers doing risk-reducing mastectomy, which in our hands reduces the risk by 95%. And if you pick up, for instance, often you pick up a small amount of things on some of those women. If you, for instance, were to pick up a high-grade DCIS in a BRCA1 carrier, and you did at the time of surgery, you would be virtually certain that you had prevented that woman developing invasive breast cancer. So that is the closest we can get to saying we have prevented a cancer. And yeah, I mean, you know, you will, you know, always have examples of people who've done everything right. You know, they've had their children early, they don't have a family history, they do regular exercise, they eat the right things, they breastfed, they did everything right, they still got breast cancer. Well, you know, the reality is that could be down to genetic factors that are not measured in family history, and it could just be bad luck. And you know, I showed you that probably a third of the component is bad luck, but you can make your luck better by reducing your risks and pushing your risks in the right direction. But you are still going to get people who are just really unlucky.
So, Ahmet, I think, you know, one place to finish up may be talking about the future. And we have this question here from Rupert Wallace asking whether, you know, we're going to be able to eliminate breast cancer by doubling down on screening and treatment, maybe screening and prevention, or do we need some major breakthroughs?
Yes, I mean, as far as I'm concerned, in my opinion, so whatever risk reduction that we can achieve is great, but we cannot prevent breast cancer altogether. Therefore, for women who develops breast cancer, we should be able to prevent them to die of breast cancer, which is essentially the vision of Manchester Breast Center, as well as our charities like Breast Cancer Now, that if we could develop patient-centered treatments, they may develop breast cancer, some of the women, but they should know that they will not die of it. So,
yeah, I mean, I think we've been making great advances over the last 30 years in improving surgery, treatments, you know, protocols for breast cancer treatments. But we've also had some fantastic new treatments that have come online for different groups of patients with breast cancer. Those with HER2 positive breast cancer now get the antibody Herceptin. Those with estrogen receptor positive breast cancer now get these CDK4/6 inhibitors that have become standard of care over the last few years and may well move into the adjuvant setting as well. And, you know, I think we do foresee further drugs coming into the breast cancer field that will continue to enable us to say that we're preventing women from dying with breast cancer.
Yeah, PARP inhibitors will come in. They're already having an amazing effect in ovarian cancer in BRCA carriers. They are the next thing, and they're very close to coming in for BRCA carriers to make a real difference.
So we talked about prevention and, you know, women not getting breast cancer. We've talked about improving survival, but the other thing is giving less treatment. And like, for example, the work that Gareth's talked about of early diagnosis. The earlier you diagnose someone, the less treatment they have. So someone gets a lumpectomy, not a mastectomy. They may avoid radiotherapy. They certainly may avoid chemotherapy. So life is a lot better, and their outcomes are likely to be better because the more treatment you give, inevitably, the more side effects that go along with it.
That's a very good point.
Essentially, early detection saves lives, right? So because if we can catch the breast cancer at very, very early stage, actually the survival rates are amazingly high, close to 100%. The problem comes from not being able to detect early enough. So
can I mention a thing? Can I mention something?
I mentioned that the biggest risk factor for breast cancer is getting older. But the second biggest risk factor is having a high mammographic density, and that's been talked about a couple of times. So one strategy is to try to understand the molecular genetics by which women have high mammographic density. Because if we are able to take a blood sample and know from a genetic screen whether or not a woman has got high mammographic density in much earlier life than when you go for a mammogram, that may make a huge difference in preventing those women or protecting those women from getting breast cancer. So I think genomic strategies to understand why certain individuals are more likely to get breast cancer than others is a really important direction for the future and will make a big difference.
And density is something that we're very much looking at in Manchester. We've got a whole load of people attacking the density question from different angles. So it's a really exciting, hot subject for us all in the Manchester Breast Centre at the moment.
Yeah, there's a question that's just come in at the end, and there is a multimodality study called BRAID that is looking at automated breast ultrasound, contrast enhanced mammography, abbreviated MRI as sort of adjuncts to ordinary mammography in women with very dense breasts.
Great, and we are coming close to the end of our event. Essentially, just to conclude everything, we are doing great progress and everything hopefully will get better. And the closing sentence actually comes from the chat who Paul sent. Research, research. We have to do more research and hopefully we can reduce, if not prevent, the death from breast cancer in the human population. So if we couldn't answer your question in the chat, sorry for that, you can always visit our homepage and also can send us the questions directly. You will find our email addresses. And you can also send the questions to Rebecca Murray, whom was in contact with you. And that actually brings me thanking all our speakers, but also thanking Joe Clark, communication manager from MCRC, and Rebecca Murray, who is the administrator of the Manchester Breast Centre. And without their help, we wouldn't be able to do this. Thank you very much all, and see you the next public engagement event. Bye.
Thanks, Arma.
Okay, thanks.
Okay, bye.
Bye, everyone.
Bye.
Thank you very much. Bye.